All right, hi everyone, it's Dr. Steph, and today I'm joined by Dr. 𝗥𝗲𝗀𝗀𝗀𝗀𝗀𝗀 Joseph to talk about billing for emergency doctors as part of my video series on billing and transition to practice. If you have a question, leave us a comment, or if you're a specialist that junior doctors turn to for billing and want to collaborate on a video lecture, send me a message in the About Me section of my channel, and if you find this helpful, don't forget to like and subscribe. To introduce Dr. Joseph, her career is quite diverse in scope and geography. She does a blend of emergency medicine and comprehensive family medicine, all the way from Toronto to remote parts of Canada in the Arctic, serving marginalized communities including First Nations, refugees, immigrants, and BIPOC communities. 𝗥𝗲𝗀𝗀𝗀𝗀 also teaches medical students and mentors young physicians. She runs the Canadian Medical Housing Facebook group to help learners find housing during their electives. All right, 𝗥𝗲𝗀𝗀𝗀𝗀, so I'm going to pass the stage to you to give us a talk about emergency billing in Ontario.
Perfect. Thank you so much, Stephanie, for that generous introduction. And to preface, I worked in multiple emergency departments, both in Toronto and in rural communities of Ontario. Billing is common everywhere, even if you're getting paid on an alternate funding model. And in one of the ERs that I worked in, I was fee for service, which means I get paid per patient I see. And that was my real learning point to really learn how to bill, because your billings is ultimately your earnings. And the more you know how to bill, the more that reflects what your income is going to be. So that's where this talk stems from and how I learned how to bill. There we go. So this is just an outline of some of the topics that we're going to talk about. I would call this talk Billing 101 for Emergency Medicine. If you've been practicing for a very long time, you may be already familiar with the codes, but this could always be a refresher as well. So I have no conflicts to declare, and I would highly recommend any physician practicing in emergency medicine to take a look at the OHIP schedule of benefits, which is where all the content that we're talking about today is going to come from, and the explanation of the codes are also there. All right. This is some of the basics that every physician must know. For every patient that you see in this province, regardless of the ER, you're going to need a diagnosis for what you saw them for, and that's a diagnostic code. It is a standardized sheet and a billing code, which is relevant directly to emergency medicine. In a shift itself, you might be busy seeing tons of patients, but at the end of the day, you should have a mechanism, whether it be electronic or paper-based, where you have a list that you generate of all the patients you saw, their health card numbers, or what kind of insurance plan they have, because that is relevant to submit your billings, what day you worked, and what hours you worked. All of these, again, directly impact the billing billing codes that you use. There's a couple of codes that is very specific to emerge, and this is the only code where an emergency doctor coming from a family medicine background or having done family medicine +1 training would use, versus an emergency medicine doctor that went through the FRCP college program would be using. And that code is H055 and H065. So if a family doctor were to refer a patient from the community to the emergency department, a family medicine physician by background would be billing H065, versus somebody who took the Royal College pathway would be billing H055. So, but this is the only code between the two emergency medicine training pathways that is different between the two different types of doctors. But otherwise, all the codes for Royal College trained and family medicine trained emerge doc is exactly the same.
And for that code, do you know if there's a cost difference? Like, for example, one pays like $25 more than the other?
Yes. So the code H055 pays more. That's the one that physicians who went through the Royal College pathway would be able to bill. It is closer to about $100, versus H065 is about $75 to $80. So there is about a 20% difference in terms of that billing code. But otherwise, every other code that an emergency doctor would use, whether you come from family medicine pathway or the Royal College pathway, would be exactly the same.
Cool.
And last but not least, there's the billing codes. And some of the things you do in emergency medicine, you need to monitor how much time you spend doing that procedure or activity. And so for time-based codes, you need to know your start time, end time, and there's formulas of how many units each time code is. For some codes, one time unit is spending 20 minutes with the patient. For some codes, 1 unit is 15 minutes with the patient. So really, even just documenting stop times during a shift, and you can do the calculation of how many units that is, can come later. But that is one thing during a shift you need to do, so that you're not coming back to it at the end of the shift and going, I can't remember what time I started with that patient and finished with that patient. So there are some time-based codes that you need to know at the back of your mind. And Again, going back, our primary resources we are referring to is the OHIP Schedule of Benefits, and it is available publicly, and there's a whole section on emergency medicine. This is your billing Bible. It's about 1,000 pages or something like that, that includes all the codes, billing codes available in Ontario for all the doctors. So the specific section that you would need to refer to is the ones specific to emergency medicine. There are a number of different handouts and websites that have summarized emergency medicine codes, and the Emergency Medicine London program has a website where they've summarized some of the codes, and this is just one of the websites that gives you a kind of condensed version of emergency medicine billing. All right, Billing 101. This is bread and butter ER code. Every single ER visit is an H code. So the H codes are very specific to emergency department, and the H codes will vary depending on the time of the day that you see the patient and whether it's a weekday or weekend. So as you can see here, on a weekday, which is defined as 8 a.m. to 5 p.m., you use the H100 series, and I'll explain that in a second. If it was a weekday evening, so we're talking now 5 p.m. till midnight, you're using the H130 series. If it is a weekend or any statutory holidays, you're using the H150 series. And lastly, night, regardless of day of the week, defined as midnight to 8 a.m., is the H120 series. We'll go into the specific codes in a moment, but again, just as an add-on at the very bottom here, you see premiums in the bottom left here. These are codes based on the time. Again, H112 can be added for certain procedures and codes you run after midnight, and H113 is for evenings and holidays. And similarly, if you do any procedures, if you did a procedure after 5 p.m., there's an extra code that you can add, E412, that gives you extra 20% of whatever on top of what the code is worth. And if you do a procedure after midnight, you can throw in an extra code called E413. It's a premium that gives you 40% extra in addition to what the procedure code is worth. Now let's go back to the H codes. That's your billing 101. We see every imaginable condition under the sun in the emergency department. There's no way they can have a code for every disease or, how much time each disease takes. So the ministry has essentially summarized what you might see into minor, medium, or major, essentially, is what it comes down to. Minor is if a patient comes in with one issue or just dealing with one system. That would be considered a minor visit. I have a rash, doc. What is it? If you say it's eczema or acne and you give a cream for it, that is just dealing with one problem, one system. So it is called a minor code. The next code is multi-system. So for example, H103, H133. The multi-system is when you're dealing with potentially multiple body systems or organ systems and addressing more than one issue itself. And then you've got comprehensive. Comprehensive always ends in a 2, like H102, H132. So comprehensive we'll talk about in next slide. But the biggest differentiator in Emerge that most doctors are usually dealing with more than one issue for a visit. Typically, we are trying to differentiate between the 3 and the 2, the multi-system or the comprehensive. How do you decide which one that you're going to bill for a given patient that you saw? So typically, if you have seen more than one system, but not done a full comprehensive history and requiring extensive workup and things like that, typically you would bill a multi-system code which ends in a 3. But comprehensive, if you read, this is a screenshot from the Schedule of Benefits. So essentially, it's a service that requires full history. So here you're doing a systems review, taking past medication history, medical history, social history, a full physical exam relevant to their direct complaint. You're deciding on treatment, and you might potentially be attending to the patient at multiple times during your shift, and then deciding on what to do at the end of your session with the patient, whether they are, for example, being discharged home, or you may consider admitting them. And if you think about it, for a majority of the visits in an emergency room, you are doing comprehensive care because you're dealing with patients that you've most likely never met before. Sometimes in a rural setting, it's not uncommon for family doctors to be working both primary care in a family clinic office and also in their local hospital emergency department or doing hospitalist work. So in smaller settings, you may see your own patients coming through the emergency department and you may already know them. But for the most part, you do not know who's walking through the door. And therefore, you do end up taking a full history, doing a full physical exam, finding out what medications they're on, pertinent positives, pertinent negatives, and doing workup and treatment plan for them. So I would argue that if you did all of that, you can go ahead and boldly bill the comprehensive code. And I think generally there's a fear of billing this. I think in the emergency community, the rumor is that if you bill too many comprehensives, you're going to get audited. Ultimately, your notes is what's going to justify whether it was the right code that you billed or not. So based on what is in the schedule of benefits, if you've done all of these, you're rightfully billing a comprehensive code. Now, for a moment, if you look at the now, some of these values might be slightly outdated by 1% or 2%, just over time. The billings, the actual dollar amount has varied. Now, for some of these, depending on the time of the day, it's not a big difference in terms of how much you get paid. So on a weekday during the day, if you bill a multi-system, it's $40 and a comprehensive is $43. So about a $3 difference between the two codes. But let's go to overnight, for example. Here, H123 is $68 and a comprehensive code is $76. So that's about an $8 difference between the two codes. Again, it's not a huge difference, but depending on the time, the difference is now more magnified. As with comprehensive care, again, this typically you're doing some sort of investigation and potentially liaisoning with other doctors involved or allied health in order to come up with a care plan for your patient. So that is our kind of not to miss. Every ER doctor needs to know these codes at the back of their hand. Very, very important here to document the time you saw the patient, because that is typically the time that decides which code you end up picking: weekday, weekend, after 5 p.m., after midnight. Moving on, reassessment code. Now, with all these H codes, they will have a code that ends in a 4, and this is called the reassessment code. So say you saw a patient, you checked in on them, decided that they have abnormal vital signs. You're going to do workup. You did your physical exam. Now you order a whole bunch of blood tests. And then you decide the patient needs an ultrasound or a CT scan, and you order that. It takes time for them to do the CT and then the results to come back. So during this time, if over 2 hours have passed, and then you're checking in on the patient to see how the patient is doing and whether the results are back in order to make your plan. And let's say when you check in on them, the results are not back yet, or you're waiting on a specialist to give you an extra opinion, and that specialist doesn't arrive yet, and you are providing active care during that time, and you're still the MRP for that patient, you can bill a code called reassessment. So between the start time of when you saw the patient first, which you all should be documenting, and the next point that you see them, or if a 2-hour period has elapsed between the two time points, you are fully eligible to build a reassessment code. So as the name suggests, you're reassessing them, and you may do this multiple times through your shift with the same patient, depending on their capacity and what they came in for. There is a maximum of 2 for each patient, for each doctor, and maximum of 3 per patient. So if a patient saw you at 9 a.m., and at 11 a.m., you ordered some tests, you check in on them to see how they're doing, take their vitals again, no results are back yet. And then again, if you check in on them at 1 o'clock and still you think you need more investigations, order the next set of investigations, and then you're still in the department. Both those time points are billable in addition to the first H code that you're going to use, the initial assessment. So you can do up to 2 reassessments. And the big thing here is you cannot, if you have a definitive plan when you come back with them, you cannot use a reassessment code. Such, for example, 2 hours later, you're like, all the results are back, you're good to go home. That is not a reassessment. At that point, you're wrapping up the patient. Or at the reassessment point, you decide this patient is going to be admitted under one of the specialists, for an example. That is now a definitive plan. It is not considered a reassessment. Now, it's a maximum 3 per patient per day. After 2 reassessments, let's say your shift is now coming to an end and the patient is still in the department, maybe we haven't figured out what's happening, or the investigations are taking a long time, or it's taking a long time to stay connected or get certain specialists involved. You may end up handing over this patient, if it's at the end of your shift, to the next doctor. Now, if they also choose to bill a reassessment code, there's a maximum of 3 per patient per day, per calendar day that can be billed in terms of reassessment. So that's the H code basics. One of the things I say, it's unfortunately, handovers are common in emergency department. Every doctor starts and stops at a different time. When you hand over, very important to let the doctor know what codes you built so that they don't build the exact same codes. Typically, if two doctors build the exact same H codes, one of their billings is going to get rejected. So typically, if the first doctor that saw the patient did the full comprehensive assessment, and for example, it was on a weekday at 10 a.m. that you saw a patient, you did a full comprehensive assessment, you can bill H102, the comprehensive code. And at 1 o'clock, the patient is still in the department, and you did a reassessment, H104. And then at 3 o'clock, let's say your shift finished and now you're handing over to the next doctor coming in at 3 o'clock. They could potentially bill either a reassessment code. You're like, I ordered a CT, please check on the patient when the results come back. So the second doctor is kind of like following or continuing your treatment journey. They can bill a reassessment code, or if for any reason they had to go back and still do another full assessment of patient or partial assessment because they were really sick, they could potentially bill a 103 if they actually can document that they did a multi-system assessment. So as long as two doctors are not billing the same code, because one of them will get rejected. Ultrasound. This is a new code, and it's become more popular in the last 5 to 10 years. There was once upon a time, if your patient needed an ultrasound, you're sending them off to the ultrasound department. But now more and more portable ultrasounds are used in the department. Emergency doctors are being trained on point of care ultrasound, also known as POCUS. And this also helps with expediting sometimes decision points for patients. There could be a huge backlog to get a formal ultrasound in your hospital, or what if it's after hours and there's no ultrasound technician at that hour in your emergency department? So this is where if an emergency doctor does an ultrasound themselves as part of figuring out what is wrong with the patient, and you document it and it helped you with the diagnosis, you are eligible for this code H100, which pays about $20, to get paid for this extra step that you did for the patient. But it comes with very specific stipulations. So for each patient, it can only be billed twice in one day. And if you did an ultrasound on the patient in the morning and 3 more times during the time they were in the department, doesn't matter. It's only twice in a day that it can be billed. In order to be eligible for the payment, you do need proof that you did the ultrasound. So you do need to take an image, and then you need to upload it into the patient chart. Now, depending on the hospital you work in and what kind of portable ultrasound you're using, or what softwares are these ultrasounds connected to, there might be some automatic ways where the images are being uploaded into the patient chart without much effort on your part. For example, there is a very portable handheld ultrasound called the Butterfly that a lot of doctors are using, like they clip it to their waist. So if you end up using a Butterfly, it's connected to a software, and if your EMR has Butterfly incorporated into the system, whatever images you're taking on the Butterfly could be kind of like through the cloud brought into the EMR. So there are now modern technologies that is quite advanced, and the fact that you can carry an ultrasound machine in your hand is quite impressive. Typically, emergency doctors, when they do ultrasound in the ER, it is quick. It's just for diagnostic purposes, and sometimes there's no lack of ultrasound. Those are the reasons why you end up doing it. All right. So find out what softwares or options are available at your hospital, if there is any available, or if you need to figure out uploading yourself. And if you need to do that, what is the safe way to do it without compromising patient information? Okay. Now, here are some other H codes that you need to be familiar with. In many hospitals, you might, depending on the time of the day or how the hospitals are run, you might end up having to do admission orders for a patient. So some hospitals, maybe in big urban centers, for example, if you need to admit someone to hospitalist or internal medicine, they will have internists on site that can come and do their consult and do the admission orders. In some other hospitals, they may not have an internist certain hours of the day. For example, at nighttime, they may not have internist. So that is where you may need to write like kind of quick temporary admission orders while the patient is under your care, so that those orders to carry them through until the appropriate specialist sees them. So if you end up kind of like deciding, this patient needs admission, but the specialist does not get to this patient until, morning, for example, and you're the night doctor, you are still the most responsible physician. And if you do the admission orders, you're essentially admitting the patient to yourself, kind of on an interim or holding basis until the specialist comes to see the patient. So if you end up writing admission orders, you're billing H105. So that is essentially kind of like, you're holding orders, overnight orders, admission orders, temporary until their next inpatient care is provided. So, I mean, you already did the work. You're not doing a full consult. You already did that at the beginning of your emergency visit. You already did the diagnostics. You have a diagnosis that is leading you to conclude that the patient needs to stay in hospital. So you've done all the work. Adding in a few admission steps in there can very well give you this code in the interim while the patient is waiting to see the specialist. Now, sometimes patients may be coming from outside. For example, it could be a transfer from another hospital, like someone was diagnosed with a certain hip fracture. They need orthopedic surgery, but that hospital may not have orthopedic surgery services, and they transferred the patient to a hospital that does have orthopedic services. So the patient might still be brought to the emerge, and for you to maybe do a quick assessment before calling the ortho. So if you're admitting to another physician at their request, or maybe at nighttime, the ortho was not in hospital, so you might temporarily be doing the admission under their name, you bill C004. Now, depending on the setting, in some hospitals, you're both the hospitalist and the emerge doc. Whoever you admitted on your watch is your patients the next few days until they get discharged. This is more relevant to rural settings. In that case, you'll be billing C933. So I want to know if there's any reason for you to be writing an admission order. Just keep in mind that, there's something you can bill for it. Sometimes in the rush of things, you're not thinking what extra codes I could be billing for, because you may build your original age code, maybe a reassessment code, maybe you did an ultrasound on the patient and bill that. But for everything that you do, you deserve to get paid. So make sure that if you're doing extra work, like filling out admissions or actually admitting the patient, you do the appropriate billings. Can't bill all three. You have to pick the most relevant one for the situation that applies to your setting.
Do you usually have a billing sheet that you do this with each patient, or do you do your billings all at the end of the shift?
So in paper-based settings, typically, the fact that carbon copy still exists is quite miraculous in 2024, but usually in paper-based settings, the emerge paper has carbon copy of some sort behind it. So usually one carbon copy goes to a billing agent, or you're keeping it to do your own billings. So at the end of each patient, I write the code on the carbon copy right away, because that is when the knowledge is most fresh in your mind about what you did to the patient. Now, sometimes if I'm walking around with a chart and I'm like, where's the ultrasound machine? Oh yeah, I'm doing an ultrasound. I don't have to remember all the codes. What I can do is on the carbon copy sheet, I may just write the word ultrasound. So it cues me later when I actually go to do the billing that I did the ultrasound for this patient. So I tend to see what I can just quickly jot in the corner of the page, or in the virtual setting. Each EMR has a different way of billing. Sometimes in my note itself at the very bottom, I write down a code, or I write keywords that'll cue me to what I did: admission orders, reassess the patient, or something like that cues me to at the end of the shift when I go back to do my billings. If I'm not able to do it on the go, that will tell me these are all the things you did for the patient. It could be something as small as, again, a rash and one code, or a patient could have been with you all night long, and every few hours you're doing something for them, and you could end up with 3-4 codes for one patient that you see. So this is where kind of having some sort of tracking mechanism that your brain can understand is necessary. People literally use a sticky note on every chart in a paper-based setting. Epic does have it's called like a sticky note option in your chart. So I recommend, if you're using Epic EMR software, click on the sticky note for every patient, little pop-up sitting in the corner. Any billing related note, just dump it in there. Did admissions, called critical, or just write words in there so that at the end, when you come to do the billings, you remember what you did. Now, over time, I'm about coming close to 8 years into practice. Some of these codes are now memorized, at this point. So I just write the codes itself. I don't need to write words like ultrasound. I know it's H100, for example. That being said, it's still a good practice, especially if you're early in career, to keep a billing cheat sheet with you or near the table you sit at, and actively think through everything you did for them, just to train your brain to just remember everything you do might be billable, so not to miss out on any codes. And that's what makes it challenging in some ways. You can be doing anything and everything for a patient in a setting like Emerge.
Gotcha. And I know some Emerge docs also collect the patient stickers, and then they might write some keywords or some billing codes on the sticker, and then they have a sheet of stickers that they bring with them at the end of their shift.
Yes. So if you have the convenience of getting stickers, so that's the challenge. I've worked in paper-based era, I've worked in sticker era, and So depending on the hospital I could be doing, and particularly in rural settings, that's where it's really all over the map. There are some hospitals that have transitioned to EMR, some have not at all transitioned. Some places you can get stickers, some places the patient's name and info is already just kind of printed on the top of the paper chart, so they may not give you a physical label. I personally like stickers because I'll just take a blank sheet of paper and I will write the start time of my shift at the top, sticker, 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 as I go along. And then it's programming your brain to remember certain times. Like you cannot forget 8 a.m. because that's the start of when the codes will change. The next time to remember is 5 p.m. The next time to remember is midnight. So those are 3 time points. And being emerge docs and shift workers, our shift could be crossing time zones, so to speak, from a billing perspective. So really, a clock, watch, smartwatch, or a physical clock where you sit is imperative in this job because the time matches. So if I'm doing a shift, let's say 2 p.m. to 10 p.m., 2 p.m. to 5 p.m. is one set of H codes, and after 5. So if I'm using a paper-based, I'll write 2 p.m. at the stop, sticker, 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 sticker. Oh, now it's 5 p.m. I just draw a line or something that cues me to think it's the next time zone or the codes are changing. Or I'll write 5 p.m. and then sticker, 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 continue in the order I saw. You will need, if you haven't already, develop a method of how are you keeping track of patients. If you saw 10 patients, 3 are gone for ultrasound, 2 are gone for CT, 1 is waiting for blood work, 1 is just waiting for X-ray. So I personally used to love the sticker model because I had like a certain coding system for who's gone for imaging, who's gone for blood work. So in one glance, I can see my billing, my diagnostics, everything in one. So I really liked the paper-based system from a coding perspective. In EMRs, it's very hard to have like all your patients with their codes, with the what's happening to them right now at any given point in time, all visually presented to you one way. Depending on the ER, they may or may not have extra features they have paid for where you can click on some button and you see the master list of your patients. Not every hospital has that luxury to have that. So yeah. But yeah, you got to have a tracking method because your tracking method is imperative to know which patients you saw, who did you hand over, what handovers you got, what handovers you're giving to the next patient, and keeping track of all the major time points because that affects your billing. Gotcha. So it gets pretty complex, pretty fast, can be overwhelming at the beginning.
For sure.
Yeah. Going back to consultations. So obviously you can get patients, the most common scenario is a patient is walking in on their own with a chief complaint, but patients could be coming in because a family doctor or a specialist or a nurse practitioner in the community or from other areas of the hospital could be sending them to the emergency department because they're concerned about something about this patient. So that is where they're kind of like, another physician is consulting you formally about a patient, about a diagnosis, or about something they're worried about. Like, I keep using ortho as an example. If somebody came in for a fracture and they're like, I'm short of breath and, I'm having chest pain, they could be having a PE on top of, with a fracture picture and immobilization. So an orthopedic surgeon who is concerned about PE might send that patient to the emergency department to work up the chest pain and shortness of breath. So when you're receiving a consult from another physician or another physician is consulting you, that is where these 2 codes, again, the only code where the FR emerge docs and the family medicine emerge docs bill differently. But these 2 codes, the stipulation is when you receive a consult from another provider, you need the name of the doctor that sent the patient in. Ideally, if the patient comes with a letter of some kind from another doctor, really helpful, that can be scanned into the computer and there's your evidence in case of an audit. So you need the name of the referring doctor or nurse practitioners. Many communities don't have doctors and nurse practitioners might be the ones in the primary care. They have actually their own billing codes. So doctor, nurse practitioner, their billing code. You may not necessarily find, especially with a phone call, like a nursing home doctor calls you and says, I need to send one of my patients in, they're very short of breath and have a fever. Sometimes you're not getting a formal letter. Every nursing home has a physician that is affiliated with that nursing home. So find out who that physician is because they might be typically the referring doctor. And don't forget to ask for their billing number, which is, just to confuse us more, different from CPSO number. So CPSO numbers are easy to find. There's a public database for it. Billing numbers, there is no public database for it, which can be challenging. Every hospital and region has a different way of handling it. I have worked in hospitals where they have like cheat sheets of all the doctors in the hospital or who have affiliations with that hospital, their names and their billing numbers. or some people have a list for that particular community or region. Particularly if it's a smaller community or region, they can put all the doctors and billing numbers on a sheet, and you can have it at the back of your hand just in case you forgot to collect that billing number. If you use apps of different kinds to do billings, sometimes the billing numbers of doctors, they may have a database that they've collected over time as well. But you absolutely need to document a referring doctor and their billing number in order to be able to use these two codes. That's the main stipulation. Okay. So premium codes, these are like bonus codes. And again, depending on the time of the day, you could be making a significantly more amount of money depending on what kind of procedures you've done. And this is where, again, keeping track of the time and what you did really comes into play. So I'll start with the procedure code, which is on the right side here, E412, E413. Any procedure you do, think in the back of your head. First of all, is there a billing code for this procedure? And secondly, is there anything extra that applies to this code, and specifically the time of the day? Pretty much nights have its own code, and weekday evenings and weekends, you can add these extras. And this will give you essentially 20% or 40% more, depending on the time of the day that you did the procedure. These premiums are essentially for kind of major life-threatening events that come through the emerge, and if you end up having them after hours, that's where the premiums come. We'll talk about G and K codes in a bit, but G codes are typically more life-threatening diagnoses coming through the door, and that's where the premiums apply for nights. You've got H112, midnight to 8 a.m. And or if it's evenings or holidays, you get H113. So actually Saturday, Sundays, and holidays, pretty much, not weeknights. I was wrong there. You can apply this extra code, an extra $20 to a life-threatening diagnosis. There is one more E code that is a premium specific to trauma. Now, trauma is an interesting one because, again, depending on the community you work in, you may or may not have trauma hospitals near you. For example, in Toronto, St. Michael's Hospital and Sunnybrook would be considered the two trauma centers. So depending on where an ambulance is coming from and if they attended to a trauma and they're shipping, sometimes they've been given the rights to bypass a local periphery community hospital and go straight to a trauma center. So if you're not at a trauma center, you may or may not be getting traumas coming to you if there's a redirect rule already in place. But if a trauma comes to you, there is a very specific premium that gives you 50% more money if you document something called Injury Severity Score, or ISS. Essentially, you can have apps on your phone or on your computer that can help you calculate kind of how severe is their traumatic injuries. And if it hits a certain score, and that score for adults is 16 or 12 in the pediatric population, you qualify for whatever you bill for the trauma, you get 50% more for that. So it ends up being a pretty nice code from a billing perspective if you remember to document this. Typically, in the act of dealing with the trauma, you're not necessarily thinking about doing these calculations, but this is something you can always come back to at the end of your shift, being like, okay, did that patient have multiple systems that were affected by the trauma, and how severe were they? And you can do the math and just document it on their chart.